Thanks for coming out this evening. I have been here for a couple weeks now. I've been talking to a lot of people in New South Wales, working in hospitals especially. I think I picked up some insights about what your system's weaknesses and strengths are. And I'm very impressed by the quality of a lot of the clinical work that's going on. But always we try to do better. So this is going to be about how to try to fill in some of the gaps that are there, utilizing tools that are available to us in the form of electronic medical records, or EMRs. So that's clinical decision support throughout this talk is abbreviated CDS, and EMR stands for electronic medical record or electronic health record. This photo, by the way, is of in San Diego. It's about, as I've been saying, it's about 2 kilometers and $3 million from my house, because it's in a good spot. All right, so we're going to start just by saying that in spite of all the great work we do, in spite of the lives we save, in spite of all the stuff we do, study after study shows that we're not getting it right a great percentage of the time. You can argue about 50% or 60% or 70% or 80%, but there's always lapses in our care. And the reason for that is multifactorial. Our care is very complicated. It's very subspecialized. People come in and out of the hospital. They're admitted for one main thing, which we do very well, but there's 30 other quality things we should be doing, and we forget one of them or 2 of them or 3 of them. So it's very hard to get them all right all the time. So we have this big gap. You can see what the numbers are for these different items. This was from a few years ago. Maybe it's a little better now. Maybe it's a little worse in some other areas. But it's clear we can do better. We spend an enormous amount on healthcare in the U.S. We're the king of overutilization and poor decisions on what we spend our money on. We are starting to get a little bit better, but every country you can see has this probably unsustainable growth in healthcare cost. So we all have to work on efficiency as well. And at the same time we're trying to cut costs, we're trying to invest in quality. So we have to spend our money wisely. We have always this tension between what all the literature is coming in and all the guidelines that are coming out, and realize that the research that's coming out, it's grown exponentially. So it's like a river of new data that we can usually only stand to take a sippy cup, at a time, not a fire hose at a time. And yet we're supposed to implement all that new stuff. At the same time, we still haven't even got the old stuff right yet. So we have this gap, I call it the implementation gap, between what we know should be done and what is done. And that's what we're going to be talking about, is trying to bridge that gap. Quality improvement is tough business. It's not for sissies, because it's not glamorous. It's often underfunded. People devalue the measurement that's needed, and if you don't do it right, it's a lot of wasted effort, time, and resource, because if you don't get results, you've just spun your wheels. So QI should have good measurable results. You should be able to know if you're making a difference, and for that you need data. In that sense, QI and research are the same, or they should be the same. QI and research, quality improvement and research, should have in common that you picked an important area to look at, that you defined who you're looking at specifically, that you have a standardized approach to what you're doing, that you measure things, that you have a safety monitoring mechanism, and that you collaborate, and that you're able to share the information as you go. That's what they should have in common. Often we fall short in quality improvement. We don't follow all these things. And it's largely because we don't emphasize the importance of them enough. And we have to start to follow these structures, or else we won't get where we need to go. I was asked to speak about quality improvement versus research, since this is the HARC Forum. And in research, traditionally, you're trying a very narrow intervention that's very properly defined, and it's that same intervention from start to finish, and if you vary from that, you just ruin the research. In quality improvement, you start with what you think is going to work, and you monitor continually, and if it's not working, you try something else. And if that's not working, you try something else. And if that's not working, you try something else. Or you throw 3 things at it, and you keep doing it until it works. And sometimes when you're through, you might have problems teasing out which component that you threw at that problem was the most important one. But in the end, you usually have to rely on other measures or other methods to figure out what had the most impact. Common sense, feedback to the front lines. It's a dynamic bundle of methods, so in that way it's different. And in research you're asking, is this intervention effective? In quality improvement you're saying, are we reaching our target? Are we reaching efficacy? Are we getting the desired outcomes? So they are different in that sense. We had to go through, as we got more and more access to data, and we knew that we're going to have a large amount of data available to us that wasn't previously available, and we were in academic institutions, we realized we had to start defining what QI was and what research was and where the borderline was, because who owns that data and who can get at it is very important to protect privacy and to make sure people aren't abusing the use of the data. So you want to provide the best data you can for quality improvement, but watch out. So we went through this. This is modified from the Hastings Center report, which is an ethics center. It outlines a lot of the things that make things QI versus research, and we worked with our, what you would call, I think, your ethics and research boards. We would call our IRB, or Human Research Protection Agencies, to come at agreement about what's QI and what's research and make sure that boundary is known. Note that QI activity is related to normal activity and you're trying to improve care. And if you piggyback something on that because you're interested, that's no longer just QI, that's QI plus research. Okay, so it's very tempting to piggyback stuff on top of quality improvement, but then you get into, is that really quality improvement necessary to achieve our desired clinical ends, or is that research? As soon as you get start randomizing, then you're starting to get into research areas, things like that. As soon as you get people who aren't involved in clinical operations or have no interest in the clinical outcomes that are involved or sponsoring the study, then it becomes maybe more research. So you have to watch out for those sorts of things. In many centers, depending on who's doing this, they'll say that it's research if you plan on publishing. That's not correct in our center, and that shouldn't be the way it is. If you have a good thing you want to share, and the good way to share is to publish, that doesn't make it research just because you're publishing that you did something that worked. On the other hand, if you're testing issues that go beyond common knowledge, if you're trying to try some novel intervention that hasn't been ever tested, then that's research. Again, if you're randomizing, if you have delayed or ineffective feedback on purpose for research purposes because you're curious, that's research, okay? And again, if you're funded by somebody else outside the system. So, having said that, there are great opportunities at this intersection of QI, research, and health information technology. And we're trying to figure out what the gaps are and what our care is, what works and how do you know, and then we already sort of addressed that research versus QI versus both. And then how do we leverage your electronic medical record system and the coming increasing functionality in that system to achieve better quality outcomes without making things miserable for the doctors and the nurses who are writing the orders, okay? And in fact, trying to make their lives better and easier. How do we do that? Because there's a lot of ways to get this wrong, and there's a lot of ways to increase work without getting any productivity out of it. So it takes a lot of careful thought and attention. Whenever we look at reliability in this gap, these are some of the things that get in the way of establishing higher reliability with or without an electronic health record. Electronic health records and clinical decision support can close some of these gaps, but not by any means all of them. Okay, so I'll be talking about that a bit more, but just keep these factors that contribute to this, and note that some of them are things like permissive clinical autonomy or physician cowboys who don't want to play with standardization, that sort of thing. The institution not being willing to standardize processes, all that, communication, coordination, etc. This is my understanding of the IT environment and the electronic medical record now in New South Wales. And this is describing mostly the inpatient environment. I think a lot of it's probably also true for the outpatient environment. But you've got mostly Cerner. Mostly it's a hybrid EMR, meaning that parts of your record are electronified and available and other parts aren't. Very important pieces of information are not available electronically. Medications in the hospital. I can't find out who's on warfarin in your hospital today. There's no way to pull that data up. There's no way to pull up point-of-care glucose test. I can't tell how much hypoglycemia you have, right? Some of the stuff's in there, but a lot of key things aren't. The data you have in there, you can't always get out. In fact, it's the exception when you can get the data out. You have to know somebody who knows somebody. You do have some improvements coming. Cerner has functionality that you have to pay more to get more, but they have some really good functionality to get data out if you're willing to pay the freight, and if you're willing to tailor what they give you out of the box, because what they give you out of the box is not going to be enough to get it done. I'll just tell you that right now. You have some boundaries between care settings, just like we do, and you've always had an expectation that EMR was going to come out and be more robust soon and that will fix things, but you've been hearing that for a long time. And we'll probably hear it for a lot longer. I believe that you've got a huge opportunity now before you start electronifying and getting the medication orders in place. And as you plan out these groups, as you got these collaborative structures together, to decide what's important and hardwire that data in to your system and standardize more easily and more centrally, using the efficient, being more efficient with very precious resources of programming, people who are knowledgeable in both clinical medicine and IT and clinical decision support. Those are hard skills to come by, and they're very precious. And they're hard, we're fostering growth of those people in our systems. And I think you've got a great opportunity. So start planning now, though, and that's the central message. Don't wait. You've already done a lot of planning, but make it an urgent matter, because it's probably the best tool you've got in the coming years to make progress. It can be your worst enemy, or it can be your best friend, and which one it is going to be up to you and the Ministry of Health and the CEC and all these collaborative groups you've got. I've got an office scan coming. Thank you. So when I do quality improvement, I have a basic checklist. You can do lean, and you can look at all these different models. They all come down to the same thing, usually, common elements. You have to have these elements in place. I'm going to stress a few parts. One, when I say real institutional support, I mean you need a will to standardize and good metrics. And institutions have to invest in those things. They don't come easy. Second, you can read the rest of the slide, but measurement is key. You can't improve things if you can't measure them. Come on. So you've got to have good measurement, and you can't accept just the publicly reported measures or the ones the government gives you, because they're almost never good enough to move the needle. They're usually made so generically and so shallowly that you can't really get at breakthrough levels of improvement using just those measures. You have to build other measures that are more relevant, more timely, have a faster turnaround that you can really apply at the point of care. I'll say that you need to have a systemic approach so that you're not relying on the individual clinician champion who will always be around to try and enforce the protocols. You've got to hardwire these things in so that people will do them because they're hardwired in, not because somebody's standing over their shoulder. And you're going to need some measures that are real-time, day-to-day, not just month-to-month or quarter-to-quarter. So we'll talk a lot about that. Clinical informatics is a big, big field, and I'm only going to pick some of them to talk about. One is the clinical decision support you get as you admit or transfer a patient within the hospital. So for that, we commonly use order sets. You have order sets too, but your order sets don't involve medicines yet. So you have this crucial breakdown of the time between when you look at the clinical decision support and when you're writing down the medications. It works much better if it's one step. And so that's what's going to be available to you when you have CPOE, or computerized physician order entry, if it's done well. CPOE can be efficient and quick, or it can be slow death. So you have to pay attention to ease of use as you also pay attention to how much clinical decision support you can provide. Month-to-month reporting is very important. Comparing across hospitals and benchmarking is important. And then you've got all these data elements in electronic health record that are stored in all these different areas. You've got lab here. You've got what meds they're on somewhere else. You've got vital signs somewhere else. And if you're a clinician trying to write a note and pull all this together, you'll go crazy unless you get better at pulling some of that crucial data that people use every day together in one place. This is what we call flow charts or flow sheets. It's called different things in different electronic medical records. It's not something Cerner is really good at. So you're going to have to push them and your local resources to build this. It's possible to do it. It's just not that easy sometimes. And if they tell you it's not possible, then call me and I'll show you somebody who's done it in Cerner. Their first answer is usually no, we can't do that. But you can do that, and it's needed because we are visual people. We see things in trends much better than we interpret things in tables, and we need to see those trends. Lastly, we'll talk a lot about these real-time reports and something I call measurevention, and that just means that you're measuring and intervening on the same day. So that you're identifying quality deficits today and correcting them on the same day instead of finding out a month from now that your care stunk. Much better to do that. I've heard a lot about the physician culture here in my weeks. I think physician culture actually is ahead in the US of what it is here. And that's multifactorial. And it's uneven, of course, in any environment. But one of the reasons that I think it's a little bit better is because more people have gone to CPOE and they had to standardize because they didn't have enough programmers to program a separate order set for every clinician in an orthopedic group, right? You've got one orthopedic order set for knee replacement. You've got one general medical admission order set. You've got one general surgical admission order set. And you can tailor around the edges, but if you don't start to standardize, you're going to run into really big expenses and upkeep costs on your electronic health record, and it won't be sustainable. So this is a lot of hospitals have gone through this transformation where they didn't even know what all their order sets were. And this is from a small 250-bed hospital where they pulled together all their order sets that were related to DVT prevention. And they weren't consistent, and they knew that they had to change. So it was an impetus to standardize when they knew that they were getting CPOE and they had to standardize their orders. So does anybody know what this is? I don't know what the hell it is. My first day at UC San Diego, I walked into the back of our hospital and I saw the staircase, and it's not in the most attractive area of our hospital, as you can see. It's back where the freight gets delivered, garbage, etc. And I've never seen anybody use it. There's never anything pulled up to it. It doesn't go anywhere. And as far as I can tell, it's never done anything. And it's been there for 13 years. And my first day, I thought, that is the most stupid design I've ever seen. But I forgot about it. I started walking by it. I didn't even see it, right? Several years later, I hired a clinician, another adult internal medicine doctor. They snapped this picture with their iPhone, and they said, "What is this for?" And I kept it. I asked them to send it to me, and I put it on this slide because it reminded me that we have such stupid things all around us in healthcare that make physicians do extra work, nurses do extra work, patients do extra work, but sometimes they've been there so long we forget they're there. So the challenge is to think about on your daily rounds, as you talk with patients, when somebody says, man, that was a lot of work, or that was stupid, don't just accept it. Don't just roll your eyes and say, that's the way it is. If you guys don't fix it, nobody's going to fix it. So whenever we talk about breakthrough levels of change, we almost always have to change the system by redesigning it. We can't just tweak around the edges. We have to blow it up sometimes and start over. So keep that in mind. That applies. I'm showing this in part because when you're implementing a big, complex new system, it's a good time to blow things up and start over if you've got things that don't make sense. Just like research, you want to define the patient population. You often want to try things on a narrow scope, one center, one floor, maybe in a room with simulation with 5 people getting simulated cases going through order sets before you ever release it. Those things help tremendously work through the bugs before you try to release it on a broad scale. I talk a lot about guidelines and protocols. Guidelines are what you get from other people. Protocols are what you make for yourself locally to define best practice. I use the word a lot just because I think you have to build protocols around what's important to you and define operationally what the things mean, operational definitions that are measurable, so that you're not just saying we're going to provide the best care for preventing VTE. You're going to say, you have to define all these things. You have to decide, are you meeting your definition of best practice or not? So this is an example from the field of DVT prevention, or VTE, venous thromboembolism, clot prevention. They have a policy that says we'll provide prophylaxis to all patients at risk for VTE until they're ambulatory or discharged from the hospital. Sounds great. But who's at risk for VTE? What's ambulatory? Does that mean that you're helped to the bedside commode by 3 nurses? Or does it mean that you're up walking outside the room 3 times a day? You have to define it so that people can measure it and decide if you're meeting the criteria for at risk for VTE or not. Same thing as you have to define what options are acceptable for each level of risk. And what about the times around spinal cord surgery? When is it safe to give anticoagulant after that? When is it acceptable not to give it? Come up with a standard. Sometimes the literature is not perfect, but you still have to come up with a standard so that you can measure against your own protocol. Jason Stein from the US, who's been out here in Australia before, and I came up with this hierarchy of reliability because we started to notice that we could predict how reliable the process was by where they were on this descriptive table. Okay? If they didn't have a protocol in the institution, they were going to be back at that 50 or 60% mark for things like VTE prophylaxis and many other things. If they had a protocol but it wasn't really embedded in the workflow and they didn't see it when they ordered patients or transferred patients or took care of them, you'd only get a little bit. If you could embed that guidance in the flow of work so that when they were doing the routine admission, they saw that clinical guidance and they would follow it, you'd get 80% of the time. Even that wasn't enough. I mean, how would you feel if they did 80% of your car check or checked 80% of your tires? Or, you've got to get higher than that, so you use these other strategies to go higher. And one of the most important ones we'll talk about is this real-time measurement again. There's keys to success and protocols. I'm not going to go into detail, but keep in mind you're trying to translate these huge guidelines into something small that people can digest, especially when you put them in order sets. So you're trying to keep it simple in access and not interrupt the workflow, monitor to see if it's working, all those things. And then you have to, after you launch it, it's not done. That's when you're starting. So many people say, oh, look, we had a problem with DVT, or we had a problem with blood transfusions. We put in an order set. Next case. They don't monitor to see if what they did was effective or not, which is foolhardy. It almost never gets you all the way there for any complex process, throwing one intervention at it and hoping that it's done. don't expect it to work. It won't work. So look for objective and subjective feedback to find out how it's working. That sums up the talk. You know, there is this big intersection. If you don't have the good data and interpretation, you can't get quality. And these data points live in different places a lot of times. Labs over here, meds over there, history over there. You've got to pull them together somehow. Most of the time, in your current state, they're in separate places, and sometimes they have separate data stewards looking over each one, and they don't want to share. They're like cranky librarians with books they don't want to get hurt. But you've got to find ways to get these together. Now I know you're looking at enterprise data warehouses or clinical data warehouses and that sort of construct. It's a key opportunity to put some of this data together, but it takes a lot of work to map this data out and to think about what data elements you want and make those discrete data points so you can pull them out. If you put everything in text, good luck getting it out. So you have to decide, how am I going to measure this? Build it in the order sets, flow sheets, documentation, so that you can get it out later. And then get these places, get this data that comes and often lives in different places. You have to get it together, and then you can get the reporting much easier. So this is what we've been evolving through now for a good 15 years at my institution, and it started before I got there. Last 12 years it's been accelerating. We're getting better and better and better at this. You have to anticipate these measures you're going to need and bake them into the process so that you can get them out, and think about it when you're building the order set or the clinical guidance about how you're going to measure that and pull that data back out. You need all these kinds of measures, including structure, process, outcomes, and balancing measures to make sure you're not overshooting. So if you're trying to control inpatient diabetes, for example, you need to have a measure for hypoglycemia. If you're trying to work at DVT prevention and adding anticoagulant, you have to look for bleeding risk, things like that. Now, this real-time measurement thing again, I know I'm harping on it, but active surveillance is very important. Some people call it technical vigilance. Sometimes I call it measurevention. That means you're identifying these patients, you're triaging them quickly, and then trying to intervene, ideally all within the electronic health records. You're not shuffling around, going from program to program. That's a real challenge, but that's what we're calling measurevention. Now, those are all the hard stuff. Now I'm just going to show you pictures of what this looks like. So relax, the hard part's over. This is an example of DVT risk assessment. Okay, this is a Cerner program. They have a special kind of Cerner, I think it's called Lighthouse. But you see the risk level. They just read the risk level and decide which one their patient's in. As soon as they click which risk level, they get only the choices that are appropriate for that risk level, and they immediately order it. There's no separation in time and space between when they choose the risk level and when they choose what they should get. In this particular example, this is a high-risk patient population that requires both mechanical and anticoagulant prophylaxis. So they have to choose one of each before they can go to the next page, or they have to cite a contraindication. So it's hardwired. Every patient gets admitted and transferred goes through this. This is a much more complicated risk model that's point-based. I'm not a fan of it, but you can use the more complicated models, but only if you give them help. So they auto-check and pull in data points that are already in the electronic health record, and it fills in this grid that otherwise the doctor would have to go through and fill in every box, right? And then, in this point-based method, they're supposed to add up the scores. Well, it adds up the scores for them. And it links that score to the right choices, again, for prophylaxis for them, and has an out for contraindications, which are defined in the text. So, not easy to look at the first time through, more complicated than it should be. I would say that's true. I'm not a fan of this particular one, but if you are going to use a complicated model, you need to help the physician through it instead of making them do it all themselves. All right, this is from my institution. This is all the patients on one ward. And each patient, you can only see the bed label here, but the patient's name, their provider, who ordered the stuff, it's all there on the same report. Everybody in the green is on an anticoagulant. So they get this report on demand in the morning. A nursing supervisor, so in some hospitals it's somebody else. In our hospital it's a nursing supervisor. And they look at all the green people and they don't have to do anything with them. They're on anticoagulant. The orange people, they're on mechanical only prophylaxis, but they have a known contraindication to anticoagulant, a high INR, a low platelet count, low hemoglobin. We've captured that. They've had it within the last 48 hours. So those are quoted orange. So really out of these 28 patients, you're trying to direct their attention to 4. The 4 who are on mechanical only or on nothing. The people on nothing are in the red. And you can tell a lot from one report. So down here on these bottom ones, it says there's no risk category declared. That means that they somehow bypassed the order set. So suddenly we find out that cardiothoracic surgery is getting around our order set somehow, and we go find out how they do that and close that loop. But we have a triage that says, well, it's okay for some patients to be on nothing if they're low risk and they meet our criteria for low risk, or if they haven't contraindication to both mechanical and anticoagulant prophylaxis. So that would be okay. But you have to do that extra bit of triage before you call doc and try to get them to correct it. This is from a Cerner site. They have everybody in their whole hospital on one side and one ward on another side. The 12 patients, I can't show you this in real time, but if they were to put their mouse over here, the list of 12 patients would come up, and so they'd prioritize their efforts based on that report. Here's what happens when you do measurevention. Okay, all 3 of these wards had 75% adequate prophylaxis by a rigorous definition in 2 separate hospitals. The arrows are where they implemented measurevention, this day-to-day surveillance. Almost immediately, they go to 95% adequate prophylaxis because somebody's taking action in real time. All 3 units, both hospitals. This is a large health system in Northern California that I was helping. They're all at 75% after they got the order sets in place. And then you can see what happens in ward after ward with measurevention when they go up to 95 to 100%, all kinds of floors. In our hospital, we reduced preventable hospital-associated VTE by 85%. So we looked at every case of VTE. We determined if they were hospital-associated or not and whether or not they were preventable. They were called preventable if they weren't on our protocol. They didn't meet those standards. And you can really bring this down if you can monitor it. Note that medicine was one of the worst offenders in blue. Orthopedics that everybody worries about generally does just fine from the start because they've been doing this for a long time. This is the kind of results we've seen in lots of these different people involved in the collaborative efforts we've run. It's almost 40% reduction in VTE, almost actually more than that now, almost 60%. This is some diabetes examples where you're trying to integrate complicated insulin ordering into clinical guidance. It's one of the more complicated order sets we do. We try to put all these cues for what you should do for the inpatient with diabetes in the order set. Again, at first glance, it looks complicated because it's the first time you're seeing it, but it's the only way they can order insulin. So they get guidance about how to dose it. They default into the recommended basal bolus sort of insulin regimen. It pulls in things like hemoglobin A1C, the last glucose, and you make sure that the correction scale is appropriate for the amount of insulin they're getting. There's lots of other examples for that. In terms of month-to-month reporting, some hospital, actually your hospitals do glucometers and check the sugars, and then that data doesn't go anywhere. There's no central repository for your data. Currently, that's what I'm hearing. I'm dumbfounded by that. It means nobody in New South Wales knows what their hypoglycemia rate is. It's one of the most common adverse drug events, always in the top 3, and you have no way to measure it. Astounding. Now, don't get me wrong, there's hospitals in the US who don't measure it either. but at least they have a repository. They could do it if they wanted to. We help them do it through the Society of Hospital Medicine. They upload their data to us. We give them back very detailed reports that they can run by ward, by service, by type of service. We help them benchmark. It tells them where they're at in hypoglycemia rates, for example, compared to everybody else in the collaborative. And you can see the huge variation, which is an indicator of you need to quality. I mean, there's like a 5-fold variation in hypoglycemia rate here. So some hospitals do this well, some do it poorly. We often juxtapose that next to their glycemic control numbers to show you that it's possible to get both good glycemic control and low hypoglycemia rates. Luckily, we're in that happy face quadrant where we're doing the best of both worlds. You know, I'm showing you this example of adverse drug events from insulin to show it's not always trivial. Some people do poorly. This is how we got our inpatient diabetes team. We had a stroke code in a patient who had a blood glucose that was very low, 8. Not really sustainable for life if it lasts very long. Like most patients who had bad hypoglycemia in the hospital, this was an older patient, not in a well-monitored area or an ICU. They were recovering from a stroke. They suffered more damage that was permanent from this event. They had this is one of the flow sheets I was telling you about, so at least we had that in place, but nobody was actively monitoring. And what was really sad about this case was that this same patient had had 3 or 4 prior hypoglycemic events, and nobody changed the dose. So the arrows, it might be too small to see, but you can see these prior hypoglycemic events, and the insulin glargine dose didn't change. The amount of dextrose they were getting didn't change. So of course they had another hypoglycemic event. Not acceptable. So we devised real-time reports every day that show glycemic outliers, and now we have mid-level providers supervised by an endocrinologist who look for people who might be off protocol, who are borderline hypoglycemic or way out of control, or who look for combinations of severe hyperglycemia but on no glargine, no basal insulin, things like that. And they're actively managing those cases and proactively going to contact the healthcare team. They're not writing the orders, but they're empowered to do auto consultation, if you will, that's pre-authorized by medical staff, and to do this monitoring. These are the most common failures for iatrogenic hypoglycemia. This is found again and again when people look at it, that they're not responding to the prior hypoglycemic event, and they fail to respond to things like interruption of tube feedings. They keep the insulin infusion going, the tube feedings stop, the patient gets hypoglycemic, and then they inappropriately prescribe. This might look familiar to you. Are you aware of the Between the Flags program here? You have color coding for vital signs. It's the warning signs for somebody who needs resuscitation. Same principle, only for glucose. Color coding to show you when you're in the range. Pulls in all this other data, and they can look at different data elements quickly in the electronic health record. Then they can go fix the order all on the same platform. So this is a good tool to use. And you get results of 40% reduction in prior hypoglycemia rates. And this is what happens when you pay attention to that first episode of hypoglycemia. You reduce the recurrent episodes of hypoglycemia. Okay? Now, all of us get interested in a topic, and we think that our topic is the most important. So we set up mechanisms so that someone goes around and checks on our topic. But patients aren't topics. Patients have a variety of things that need to be monitored by a variety of different people. So this is an example of what we call the dynamic dashboard that pulls a lot of different elements together. It's like a dynamic quality checklist, if you will. This is for an ICU population, and it pulls together things like glucose and DVT prophylaxis, GI prophylaxis, head of the bed elevation, some rapid response criteria elements, and at a glance you can see what's going on the whole ward and what might need attention. And it's posted where nurses and doctors see it together and where they do interdisciplinary rounds together. so that they're referring to this a lot and trying to address these deficiencies or potential warning signs early. All right, so that's a lot of ground. I just want to point out again that the electronic medical record is a tool. It's not a panacea. It's got great potential to help if you put the investment into it, if you hardwire the measures into it, if you decide what you want it to do in advance and design it for that purpose. The thing that comes out of the box from Cerner is more related to administrative stuff and documentation and check boxes, and it's not going to be adequate to get the job done out of the box. Also, keep in mind that there's a dark side to electronic medical records. Copying and pasting notes, right? Documentation, it becomes electronic and meaningless because nobody's reading it. It's so much documentation, nobody could possibly read it, and it's not even done accurately. I'm a great advocate for thinking we should cut down on what we document and increase the reliability of what we document, prioritize it better. And then we have these stupid things where we have 3, 4, 5 different ways to record ambulation, and we have 5 different people do it, and it's stored in different places and used for different purposes. Why don't we think about it and have one way to document the ambulation and port it to everywhere else where that parameter is needed? So that's the sort of challenge I'm asking you to think about. I think EMR and the CPOE systems, they will undoubtedly improve medication safety in many areas right off the bat. Legibility, routing of orders, timely review by the pharmacist, all those things will help. But you also have the capacity to replicate errors in the chart automatically. Medication administration and reconciliation can go from a benign process where you're just matching up med lists to write prescriptions to you're actually executing an active order. So if you make a mistake now in MedRec, then the patient gets a wrong prescription. So it becomes a lot more serious potential for harm if it's not done correctly. And a lot of times we found it's not the electronic health record's fault, it just made flaws in our system much more apparent to us. And you probably have already seen that a lot in Cerner, I'm guessing. The impact of how well this tool goes for you is dependent on things that are largely not dependent on technology, but more dependent on culture, forethought, intelligent use of resources, and how much you can tailor what comes out of the box into your unique environments. I think you've got a great potential here, again, because you have most people on the same platform, and you have at least some way to try to promote common tools across those platforms. I'm always in this state where I'm hating the electronic medical record and loving it at the same time. The products that we have are not designed for quality and safety and communication. They have their roots in billing, administration, things like that. So we have to make them better than they are, and you can do that centrally and locally, but don't have those two fighting each other. Try to do some of the most important things centrally and then let people tinker around the edges, but try to do at least some of it centrally, the most important things, to decide jointly what you're going to look at for both quality and research. We came up with the phrase Occupy EHR. You know, they had the Occupy Wall Street movement. People were really mad. Well, we get mad about the EHR. We get mad in a frenzy about how frustrating it is to work with these tools that don't do what they should do out of the box. It's not all their fault. It's a hard, complicated business. But you really have to work ahead and plan ahead to minimize limitations. And just keep in mind that these limitations I showed before, you can't fix all of these with the EMR. It can help some of them, the ones that are emboldened, but most of it depends on things outside of technology and the EMR. I think that's pretty close to on time. I'm not sure, but I think I'll stop there, and we're I think, hold questions till later. Is that right? Okay. And so thank you for your attention, and we'll be
Thank you, Greg. I'm sure that'll give rise to many questions, but we will hold questions until the panel session. I now invite Professor Joanna Westbrook, who's from she's the Director of the Centre for Health Systems and Safety Research at the Australian Institute of Health Innovation at the Faculty of Medicine, University of New South Wales. And Joanna will respond. Thank you.
Thank you very much. Bob, it's a great pleasure to be able to give a local response, and it was an excellent presentation from Greg. I think you're going to find that we're in strong agreement on many of the themes about the enormous potential that clinical information systems have, but also about the incredible challenges that they bring. And we've got many of us are experiencing the same things that Greg's been speaking to us about. Greg started his presentation with the slide from Beth McGlynn's study, which was published about a decade ago in the United States. And many of you will know that last year we published a similar study, which was an extension of the Beth McGlynn study, but in Australia, where we looked at 1,000 patients and over 35,000 encounters to look at what percentage of them received appropriate care. And, you know, it's quite... I don't know if it's pleasing or not to see that 57% was the answer we got. It was 55% roughly in the McGlynn study. But once again, you can see that there's enormous variation between different conditions. And really what this is just constantly telling us is that we have plenty of scope for improvement. And I think one of the positive things about clinical information systems is that it's giving us a new tool to start tackling some of these perennial problems, and not only about being able to do the things we're doing currently in better ways, but actually thinking about new models of care. And one of the points Greg made was it's a chance to rethink how we do things. And one of the challenges is that we don't want to embed current ways of working necessarily and hardwire them into the clinical systems we're introducing. So I just really wanted to give you a few examples. Many people in this room will be familiar with these, of the ways in which we're currently using decision support in systems in New South Wales, and we've obviously still got a lot of potential. The first experiences most hospitals had was with electronic ordering. Many hospitals have had electronic ordering for decades, some more recently, and this really provided us with the first opportunity to start looking at how we could use decision support. And as Greg pointed out, decision support is a very wide spectrum of quite simple decision support to highly sophisticated things. So the most simple type of decision support can be just having very structured forms so you get more complete and readable data. And certainly with electronic pathology ordering, this was one of the things that we were able to do. So one of the problems, as an example, was when pathology labs were getting gentamicin and vancomycin specimens, only about 16% of them in the paper-based system would actually specify whether the specimen was peak or trough. But once you introduced an electronic system, you know, that substantially increased because they just implemented a tick box to trying to remind clinicians to include that information. You can move then to looking at some of the, taking some of the quality improvement work which is underway to actually say how can we embed that into electronic decision support. And this was an example where it was a collaborative project between cardiology, ED and pathology, where they were concerned about the number of repeat troponin tests of patients presenting in ED with chest pain. And so they started the process where they had a paper-based guideline, and you can see a copy of it there, and they did feedback and audit, and then they had the opportunity to embed that same decision support in their ordering system, which would pop up every time a clinician wanted to order troponin. And we looked at what happened over time in terms of the proportion of patients that were receiving more than 3 troponin tests within a defined period of time, and you can see with each intervention there was a significant reduction. But what I would really like to spend more time talking about today is electronic medication management systems. As many people know, it's close to my heart. Lived with it for a few years. And this is where, as Greg pointed out, we're probably going to get some of the greatest benefit from clinical information systems in terms of improving outcomes. We had the opportunity, this is a screenshot from an electronic medication management system. For those of you who may not have seen it, different commercial systems have different interfaces. So we had an opportunity when two major teaching hospitals in Sydney were implementing electronic medication management systems, and were very kindly happy to work with us to undertake this research. In New South Wales, really, we're still at the beginning of this process, but I'm sure Kathy might tell us about how this is really going to be ramped up very soon. And so we had one hospital introducing the Cerner medication element, and another hospital implementing MedChart, which was is now owned by CSC. Originally was iSoft. Both systems had limited decision support at the time we did the study, so we were able to compare two different commercial systems, which is quite unusual internationally. There are a few studies which have done this, and we looked at prescribing errors on the 6 wards before and after the introduction of the system. In summary, the method we used is we had experienced clinical pharmacists who would review every patient's medication chart on those 6 wards, and during the course of the study they reviewed over 3,000 patient medication charts, and during the process they identified 17,000 prescribing errors, which they then classified. And we classified them into 3 categories. So we looked at procedural errors, so unclear, illegal, and incomplete orders. We weren't interested in things such as orders that hadn't been signed, or there wasn't a signature that was readable. They didn't seem to be immediate safety risks for patients. Then obviously clinical prescribing errors, wrong dose, wrong drug. And we were also interested in, once the system was introduced on the intervention wards, whether there were new types of errors that the system was actually creating. And a classic example of this would be that a clinician is selecting a drug name from a drop-down menu item and clicks on one above or below the one that they wanted, and a type of error that wouldn't happen in a paper-based system. So this was the data at baseline. I mean, one of the challenges in doing these sorts of studies is that we often don't have good baseline data about the size of the problem that we're actually trying to solve. So these were the prescribing error rates on the 2 hospitals, and you can see obviously there are a lot more procedural errors than there are clinical errors, which is reassuring, and at each hospital there was somewhere between 1 or 2 clinical error per admission. Now, we're obviously interested in really trying to tackle the serious prescribing errors, and so for every error that was identified, it was classified on the Sax severity scale, and we wanted to focus on those last 3 categories where the errors had the potential to cause permanent harm to patients. So when we looked at the baseline data and we looked at these serious errors, what we found was, despite the fact that the hospitals at baseline had quite significantly different rates overall, their serious error rates were not significantly different. So both had around 27 serious prescribing errors per 100 admissions. So what happened when we introduced the electronic medication management systems onto the 3 intervention wards? We saw a significant and quite large reduction by over 50% in the overall prescribing error rate. So it went across the 2 hospitals from 406 per 100 admissions to 185. And when we compared that with the control wards during the same period of time, they saw no significant reduction in their prescribing error rates. When we looked in more detail about which errors were actually being eliminated, it was very clear that it was the illegible, incomplete and illegal orders, which you would expect. But this was really quite a big change. There wasn't a difference between the 2 commercial systems. They were broadly in the same quantity in terms of their reduction. But I think it's important to compare it against other types of interventions we've been trying to throw at this problem. And so if you look at the National Inpatient Medication Chart, which we put in place a couple of years ago, and of the evaluation research that's available, that looks like it reduced errors by somewhere between 5 and maybe up to 10%. What happened with the serious errors? Well, when we looked at the intervention wards, we saw that there was a significant 44% reduction in the serious errors. So it went from around 25 per 100 to 14. And once again, we looked at the control wards and there was no change in their serious error rates. So, I mean, this was very pleasing results, but perhaps quite surprising in some ways. We hadn't expected this size of improvement, but there is still enormous scope for further improvement if you can look at that rate of 14 per 100. And this is where decision support really can be most targeted. So, as I said, these systems didn't have a lot of decision support in at this point in time, but there were a few rules, and we wanted to look at whether there was any evidence that specific rules were having an impact. One of the most frequent errors at baseline across the 6 wards were duplicate therapy errors. And so one of the systems, the MedChart system, introduced a duplicate therapy alert, and this is an example of one of those alerts. So it comes up with the patient has recently been prescribed or given paracetamol 500 milligram tablet. Do you want to override this and continue the prescription, or do you want to actually stop this order? And what we found when we looked at the data for the MedChart system, that they saw a significant reduction in duplicate therapy errors. The Cerner system at this point in time didn't have a duplicate therapy error, and we saw no change in those. So it was good evidence that when you can have a well-designed, targeted alert, it's very useful. But interestingly, when we did qualitative work with the clinicians, this was the alert which annoyed them the most, because it comes up very frequently. There was a very low threshold by which it would be generated. So this really then leads me to, very briefly, the other part of our work. So we like to do a lot of quantitative work, but we also want to go in and see how these systems are affecting clinicians in everyday life. So we do a lot of observational work. And I just wanted to show you a very brief video. These are 2 clinicians, a registrar and a resident, in the very early days of implementing this system. And it gives you a sense of how they were learning to integrate the system into their everyday work. Stand up a bit.
Desmond, 2.5.
The problem is that they're going to give, because you've got to pick the highest dose, they're going to give 5 milligrams.
So just to let you know what we're doing, we're charting a crisis pack for a gentleman who is possibly going to die in the next few days.
We'll take a few days to chart this.
So I think, a picture tells you 1,000 words about how they were starting to think about how they were going to use this system. And possibly in a slightly surprising way, the fact that they decided to do it together, that they'd handwritten all the orders out first before they were going to type it in. And obviously, her frustration, it's going to take a couple of days to chart the crisis pack, is an indication that, it really takes a while before you become more efficient. I'm sure if we went into this same site now a couple of years on, that work practice would have changed. But it does, you really need to understand what clinicians are experiencing and to give them feedback about the fact that this is actually producing some of the benefits, and it is worth going through this very difficult period. So one of the things we've clearly learnt is that context really matters with decision support. There are all sorts of decisions about when in the process should you be alerting or providing decision support, who you're actually targeting, who's making the decisions, and also how do you design the alert, how do you show an alert that's really important and those that may be just there for information. These are all sorts of important decisions that have to be made. And I wanted to share with you a study. This is like these are our ward rounds. that was led by Melissa Basari, who's one of our research fellows who's here tonight. And we wanted to actually say, well, what happens when decision support comes up during a ward round? What reactions do clinicians have to it? And so what she went out and did is she followed ward rounds for around 60 hours, and she observed 14 teams to look at what happened when they were prescribing and what did they do in response to the alerts that came up. Well, first of all, she found that nearly half of all the orders that they made generated an alert, which seems a very high rate, and this was a system that was still seen to have quite low levels of decision support. 17% of the alerts were read by the clinician, and she was very generous in her definition of a read, so you just had to really just read the first word or so and that was read. She found no prescriber actually went and read the entire alert, and no prescription was changed at all during ward rounds when that was happening. So, you know, what was going on? Well, any of you who've been on a ward round would not be surprised to know that it's the senior clinician who is making the decisions, and which is most, you know, quite appropriate, and it's the junior clinicians who are actually entering the order. And so the decision maker in this case is not receiving any of the decision support, and probably would have been maybe annoyed about it. And we also saw no junior doctor who actually said, hang on, I've just received an alert, you know, should we discuss it? So I think it clearly tells you that, you know, you really have to think about what and whose behaviour you're trying to alter and what setting are they in at the time. And we came up with a quite radical suggestion in this paper that perhaps during ward rounds you should turn up the majority of the decision support, because all it's doing is teaching junior clinicians to ignore alerts. But we did say, well, who might most benefit from decision support? And so then we looked at junior doctors at night. So we had another study where we sent in someone to follow doctors for 65 hours at night. And we found a slightly different picture at that time. So they were much more likely to read the alert, 78% read, and 50% actually read the entire alert. And also in 5% of their prescribing decisions, they actually made a change to the prescription. So I think these are just some, even though they're quite small studies, provide some good examples of how you really need to think about who you're trying to influence with decision support and how you're going to go about it in the best way. So in conclusion, I think you can see there are many common themes that have come up with some of the examples that Greg was given, probably in more sophisticated decision support. But what is at the heart of it is we've got to understand the problem that we're actually trying to solve and have some good data about the size and the nature of that problem. And we also have to understand what mechanisms by which we think the decision support is actually going to help us solve that problem. Measurement, you know, it's so important. You need baseline measurements, you need post-intervention measurements, but you also need to be looking for both what you expect to see and things that you don't expect to see. Context is incredibly important. And probably perhaps the most important message of all is that you've got to ensure that what you're putting into the system you can take out. And we're still struggling with many of the systems we're dealing with at the moment with trying to get the data out. And I think most people assume that if you put it in there, it's in there, so we must be able to get it out. But it actually is incredibly difficult at the moment. And that's really the key to if we're going to say, is this decision support working or not? We need in almost real time, as Greg says, to be able to get some data saying, you know, how often is this alert firing? What are doctors doing in response to it? And are we able to link that data with particular clinical outcomes, which he gave some great examples of how they've been able to do that. Finally, it's very clear that more decision support is not better. And you really need good governance structures around this, who's going to make the decisions about it. And it's about deciding what you're going to put in and also what you should take out. I mean, we're having some discussions with some hospitals to actually try to work out processes to get agreement about what rules should come out of the system. And finally, I think the importance of very clear of sharing experiences. Not only, I mean, it's amazing how many times I talked to somebody else in another hospital in New South Wales who didn't know, you know, something was going on or someone had already done that rule. And, you know, sharing the international experience and not reinventing the wheel is absolutely crucial. Thank you.